Good evening, everyone, and thank you for joining us. My name is Melanie Ionase, and I'm the Physician Relations Specialist here at Rothman. Tonight's webinar is with Dr. Jose Canseco. His office locations are Bordentown, Hamilton, and Pennington. Topic that he will be covering this evening is low back pain and spinal stenosis, diagnosis and treatment options. In this lecture, Dr. Canseco will guide us through the causes, symptoms, and treatment options for these common and often debilitating conditions. Low back pain affects millions of people worldwide and can significantly impact daily life and mobility. Our goal this evening is to provide you with an understanding of these conditions and to offer practical advice on managing and alleviating symptoms to improve your quality of life and taking steps towards a healthier spine. So just a few quick notes. At the bottom of your screen, there is a Q&A icon, so you can ask questions throughout the entire lecture. Also in the chat box, I will share with you Rothman's phone number if you'd like to make an appointment, or as well as my information if you need any assistance. So without further delay, Dr. Canseco and his physician assistant, Ryan Urban, thank you so much for joining this evening.
Good evening, everybody. I'm really happy to be here. When I spoke to Melanie and a few patients in our practice had requested information about lumbar spinal stenosis, I figured it was a good way of communicating with you guys and speaking about some of the things we do and how we treat back pain. And it's a very common problem. So I'm going to talk brief overview at lumbar spinal stenosis and what it is, how we diagnosed it, and then we'll go over brief treatment options. This is by no means going to be a thorough discussion of surgical treatment options. We will talk about non-operative options, and Ryan will help with that because that's what most people need. And then, if you feel that you're having symptoms that would be explained by this, then feel free to make an appointment with us, and we're happy to see you and go more in detail about what the options are for you. And so again, lumbar spinal stenosis. So what is it? What spinal stenosis, if you look at the name, spinal means about the spine, and stenosis is a medical term for compression, tightening, or squeezing. So it literally means squeezing of your nerves or your nerve tissues. It's very common in the cervical spine and the lumbar spine. In the cervical spine, it can lead to something called cervical myelopathy because it compresses your cervical spinal cord and then leads to dysfunction, problems with balance, or problems with hand dexterity and coordination. I actually gave a talk about that last year, and you can find it on YouTube. And in the lumbar spine, it can lead to back pain, leg pain, and neurogenic claudication, difficulty walking. And we'll go over that more in detail. And a lot of my patients always say, well, doc, what caused it? And unfortunately, it's time, it's aging, and it's arthritic disease. As we age, we have wear and tear in our joints, just like people need knee replacements when they have knee arthritis. Well, you develop arthritis in your back, and unfortunately, we don't have a spinal replacement at this time. And another form of developing this is genetic. It has been seen in twins, and we'll see that in a minute. Or trauma, you have a fall, you have an injury, you have a little bit of slip of a disc that decreases the volume of your canal. You can see in the picture on the right side, at the top is a relatively normal canal with some arthritis. You see in the middle, there's a space in the canal. The one below, you see arthritis, the bone is overgrown, and instead of seeing a heart-shaped area, you see this little triangle. And just think about it, your nerves have to fit what was in that heart-shaped area above has to fit in that little triangle. So you can see those nerves are really feeling the tightness in there. So that's in a nutshell what it is. This is the part of I wanted to describe. Well, people say, well, why did I get it? In some studies, there's some suggestion that it does run in families. They did a study in Finland, and they published it back in 2014, where they looked at twins. It was about 600 male twins between 30 and 70 years. And they looked at their spines and said, okay, well, is there compression in the middle of the spine or in the outside of the spine? And they looked at it on MRI, and also they measured and see what the difference in the sizes would be. And they did see an association between in twins that stenosis in the middle of the spine led to compression, and the size of the spinal canal and the dural sac was very correlated to genetic components, and the generation of the disc over time led to decrease of the size of the canal and to symptoms. And so, one of the reasons what you may say, well, yeah, it runs in my family. Well, yes, it can be genetic. And the other one is aging. And what I mean by that is as we get older and we get arthritis, our spine changes. On the left side of your screen, you see a relatively young spine. You see the bones are smooth, the nerves, the spinal nerves are not compressed. The canal where the spinal cord is, you see wide open, and the disc is smooth, round, and unherniated. And then on the other side, on the right side, you see an arthritic spine. You see the overgrowth of bone. There's bone spurs that you see in the spine. The bone spurs can grow inside into the nerve or behind towards the spine and the joints. Then you can see bulging of the disc or even a herniation of the disc that leads to impingement of the nerves. And that overgrowth can lead to spinal stenosis and symptomatic disease. Another way of looking at it is in this diagram. Arthritic disease leads to narrowing of the spine. On the left side at the bottom, we see a healthy spinal canal. And on the right side, again, we see a different picture of spinal stenosis. Above right there, you can see spinal stenosis because of degenerative disease of the facets. The facets are the joints in the back of your spine. A lot of my patients come to doc, I don't have any nerve pain, but my back hurts. Well, one of the reasons could be that the joints in your spine have developed arthritis. You lost the cartilage and there's inflammation. And it's this little leaflets of bone that you see in the back of the spine, and that can lead to pain. If that grows outwards, you may not have stenosis or compression of the nerves, but you're going to have back pain from arthritis in the joints. But if it grows inwards and compresses the nerves and the neural elements, then you're going to develop spinal stenosis. And anything can thicken. Not only the bones can lead to bone spurs, you can have thickening of the ligaments, like the ligamentum flavum, which is the ligament in the back of the spine that can lead to decreased volume in the canal. You can also lead to thickening and bulging of the disc. You can have a disc herniation. The disc height can decrease. And if you think about that, if the disc phase decreases, look in the upper right corner, the above disc seems to be normal, the lower one is shorter, and as you lose the height, well, then the exiting nerve has less space to come out from, and that leads to compression. So it's all wear and tear and arthritic disease. This is MRI that I found on the internet. These are all my patients. These are examples of an MRI, a normal MRI and an MRI with stenosis. Many of my patients present like this. You can see in the middle a normal lateral view of the canal. And then if we do a cross-section, slicing you like a loaf of bread, and we have one of the slices, you can see on the right side in the middle, a round canal with little dots, and those are your nerves. If you age and you develop spinal stenosis, you can see in the left lower corner a little bit of a slip of the disc. You see that the upper vertebrae, it's slipped forward compared to the lower vertebrae. And then there's thickening of the tissues in the front and the back of the spine. And you can see compared to the level above and below, there's narrowing of the canal at that level. And if you do a cross section again, you can see on the bottom right area, you see bulging of the disc, thickening of the joints, and thickening of the ligaments. And you again see that little triangle. Instead of having a round circle where the nerves go through, imagine all those nerves trying to go through that little triangle of space. Of course, they're not going to be behaving appropriately because you're squeezing them, you're squeezing blood out of them, nutrition and space from them. And so they can't do their job appropriately, and that leads to the pain you experience. What are the symptoms? Patients are like, well, what are the things that how does this present? So patients always complain, in most of the time, of back pain, and not necessarily leg pain, but back pain with walking. That's that arthritis in the joints. And as the nerves start to getting pinched, you can develop numbness and tingling. We call that paresthesias. This funny sensations in my legs, pins and needles, or like ants crawling on your skin. If the compression is significant, you can have weakness of the legs because the nerves can't reach the muscles appropriately, so you have some weakness. You can have radiculopathy like sciatica. If the nerve gets impinged, you can have pain in the leg as well. But the biggest symptom that I get is neurogenic claudication. That means, hey, doc, I can't walk more than 10 feet without having to stop because my legs develop this pain. That's that compression of the nerve, decrease blood flow into the nerves, and decrease ability to do their job, and that leads to pain. And that's what is neurogenic claudication. In the middle, you can see there's pain with standing and pain with walking, particularly when you extend your back going up the stairs. But many people tell me, doc, if I go to the grocery store and I grab a shopping cart, I can walk all day. Well, guess what? What happens is you're bending your back, you're increasing that space artificially, and then you don't have that compression, so you can walk a lot more than you would be able to if you didn't have the shopping cart. So we call that the shopping cart sign. This is a little better explanation. This is the primary symptom of spinal stenosis, what we call neurogenic claudication. You see on the left side, thickening of the nerves, thickening of the disc, thickening of the ligamentum, compression of the nerve sac and the nerves. And what happens is you start walking and you develop pain. You're having symptoms of claudication. You sit down, you rest, pain goes away, and you can do it again. I've had patients that tell me, doc, I can work 15, 20 minutes and I have to stop. I have patients that tell me I couldn't walk from the car to your office without having to stop. And so there's different degrees of stenosis and disease. And that's why having advanced imaging like MRI is very helpful in letting us know what kind of treatment we're going to offer you. Another a diagram that can explain neurogenic claudication. On the left side, you see standing and walking made the pains worse. Why? Because there's heaviness of the legs, decreased signaling getting to your muscles, and so as the legs feel heavy, you stop, you rest, they feel better, you can start walking again. And this is important to know because we have to differentiate neurogenic claudication from stenosis from cardiogenic or cardiovascular vascular claudication. And some patients say, Doc, I don't have spine disease. I also have leg pain when I walk, but that's because my blood vessels, arteries, or veins are not healthy, and so the blood supply to your muscles directly is not reaching them appropriately, and then you develop pain in the legs. The difference there is if you stop in vascular claudication, your pain gets better. And if you but in neurogenic claudication, bending forward leads to you can continue to walk just because you increase the space for the nerves. If you had vascular claudication, leaning forward is really not going to help you. And so that's why it's very important when we do an exam, we always check the pulses in your legs, because if the pulses are not very strong, we can also send you to a vascular evaluation to make sure that you have either or both. Some patients have a combination of both. This diagram I find it's always hard to find distribution diagrams where people say, well, where I'm having the pain and when it's coming from. And you know, if, for some of you, if you have been to my office, you see I have the dermatome map on the wall. And this is one of the figures that I found that really explains it very well. So some people have compression at the L2 level, and we're going to go back here in the spine real quick. And so if you see this, you can see the bottom level, the triangle is the sacrum. And then the last one is L5, 4, 3, 2, 1. Those are the lumbar levels. And depending on the lumbar level, you have roots going to the legs in different regions of your leg. And so we go back here. Most patients, in many patients that have L2 compression, they develop pain in that groin area, in the hip and the thigh. L3 shoots more in the inside of the thigh down to around the knee. L4 is more in the front of the knee from the thigh all the way down to the inside in your shin. And then L5 tends to be on the lateral aspect of your leg, on the outside aspect of your leg, down to the outside aspect of your calf and the top of your foot. And sciatica, the classic symptom is the S1, it's in the back, it's in your buttock, in the back of the thigh, back of the leg, all the way down. And so those are the areas. So depending on where your symptoms are, that's when we know, okay, well, that's likely the level where the compression is coming from and what we need to address either with conservative treatment or surgery. This is another picture. L5 tends to be a little bit complicated because it presents differently in many different people. It can either be on the inside of the foot and top of the foot with the outside of with the inside of your shin, or it can be on the outside of the shin and the calf. So you can see they're different. Most people complain about in the top of the foot and on their shin and anterior aspect of the lower leg, the front of the lower leg. Now, one thing that I did want to talk about very quickly is, well, is this an emergency? Well, and not necessarily an emergency all the time. Many patients come and tell me, you know, Doc, I've had pain symptoms for many years. I know my walking has been difficult for 10, 15 years, or, you know, 5, 6 years. I have that pain shooting down my leg, but, you know, I stop, or I use a walker, or I use a shopping cart, and then I can be on my way without a problem. And, you know, when I see patients and they're hesitant to pursue surgery initially, we always start with, you know, with conservative treatment. Ryan will talk about it in a minute. With physical therapy, we can do injections, we can do medications, we can do a home exercise program. And for the most part, many patients do get better, and that's why we don't need to do surgery. But as the symptoms progress and they're worse, then that's when surgery becomes indicated. The only time where I tell patients they need to call me on their way to the hospital, or come to the office back, is if they start developing issues with their bowel or their urinary system. They're like, you know, that it's very difficult to pee. It takes me a long time to go to the bathroom, and it's changing very acutely over the past day or so. It's acute change. You have urinary retention. You can't go to the bathroom, or you lose control of your bowel and bladder, and that's an acute change. I'm not talking about issues you've had for years or months, or even, you know, several weeks. It's something that happened over a course of a day or two. That's when we have to intervene. If you have the changes over several weeks, then you also need to be seen promptly. But surgery may not necessarily have to be right away. I'm talking you have loss of bowel or bladder function within 24 hours or so, that needs to be addressed right away. Or if you develop significant weakness in your legs, if you have a foot drop that's getting worse and not getting better, we have a very short period of time where we can act to prevent that weakness from being permanent. The literature varies on it. It's 3 to 6 weeks, but in general, we want to address any weakness that's not getting better with therapy within 6 weeks to prevent any permanent damage. And the last one is saddle anesthesia, having, perineal in your general area, some numbness, tingling, or just pins and needle sensation. That may be a sign that there's compression of the nerves, and that is getting worse, and that will prompt us to bring you in, getting an MRI immediately, or send you to the emergency room to get a quick decompression. Now, in my practice, I've been doing this for about 10 years. I've only seen emergencies like this 2 or 3 times. And so it's not something that presents very common. And most of the time we can plan electively a surgery that addresses your symptoms without having to rush and do everything last minute. But I wanted to bring this to your attention in case you're having symptoms that are more like this, and you should definitely seek a provider, us or someone else right away, because then you may need treatment more urgently than others. And so now we reach the part where treatment options, and I want to spend a little bit of time on this. Ryan is going to speak about the non-operative treatments, and you can see there home exercises, physical therapy. You can see one of our partners, their physiatrist. They can give you epidural injections if you're having radicular pain, which is the pain shooting to your legs, like sciatica. They give an injection close to the nerves that decreases the inflammation. Pain gets better. The other is injection at the facet. Remember those joints we spoke about in the back? If you have arthritis in the joints, they can inject those joints with lidocaine or steroids, decrease the inflammation, and give you some form of pain relief for a period of time. The other option is the medial branch block. If you have pain in the joints in the back, not in the legs, there's little nerves that we cannot see during surgery that innervate those joints. They can block those nerves. If the pain gets better, then we can send you to get something we call a radiofrequency ablation. They put a really hot probe, a tip of a probe that's really hot next to those nerves. They burn those nerves, and the pain subsides for a prolonged period of time. Some patients tell me that they get pain relief for 9 months. I've seen people tell me they don't have any pain for up to 2 years. So that's another option to get to seek pain relief without surgery for either people that cannot have surgery for medical conditions, or they don't want to get surgery because of some personal preference. And then also we have some pain medications that we can prescribe, not narcotics. Narcotics is not necessarily something that we prescribe in this disease because it doesn't help necessarily. And also, if you're older and it leads to drowsiness, you can get into trouble. But I'm talking more of anti-inflammatories and muscle relaxants, and Ryan will speak a little bit more about that. When you fail those treatments, then we talk about proceeding with surgical intervention. And for the most part, as long as you don't have an instability in your spine, a slip disc that gets worse or better with movement, we can proceed with a decompression. We can remove the bony and scar tissue or arthritic disease that's pushing on the nerves, safe enough to prevent the spine from being unstable, give room to the nerves to breathe, is what I call it, to function properly. And that would lead to improved ability to walk longer distances because the blood flow to those nerves and the space for those nerves is appropriate. And we can also decompress the tunnels where the nerves go out. And so we can decrease your radicular pain. The sciatica, the pain shooting down the leg that you had, can be relieved by that because we remove the tissue that's compressing the nerve, either bony, disc tissue, or arthritic disease from ligaments and the soft tissues. Now, in some patients, the reason they have spinal stenosis is because not only do they have arthritis, but they have an unstable spine. And I say one of the vertebral bodies slips forward and it pinches the nerves in the back. In that sense, in some instances, not only do we have to decompress to give room for the nerves to work, but we have to fuse that level to prevent that from slipping and continue to compress the nerves. And for that, we do a fusion, and it depends on what your disease is. If your disc is collapsed or not, we can treat that with either putting cages in between the bones and screws, or just screws to prevent an instability. And there's many ways you can go, from the front of the spine, the side of the spine, the back of the spine. But like I said, that's a more detailed talk when surgery. We can definitely talk to Melanie to have a talk about those options later. But that was a last resort. I'm always a very conservative provider. I do treat everybody non-operatively as long as we can, and only when it fails and it's absolutely indicated and necessary is surgery becoming an option in my practice, because not everybody gets better with surgery, and surgery does come with complications. So you want to make sure you do it in the right person at the right time, and that's the only way you can ensure better outcomes. And so that's a brief overview. I want to spend 20 minutes or so talking about this condition. It's very common, but it's not very well understood. Most people think that, oh, I need to see the spine surgeon because I have sciatica or a disc herniation, but not always. Sometimes you can have conditions that are more chronic, that develop slowly over time. And if you reach a point where you've tried everything and you haven't and found relief, you can always come see us at Rothman. We don't always have to pursue surgery. You can see me or Ryan, and then either we can refer you to our physiatrist, Dr. Suri in our area, and many others. and then you can proceed with injections. And we also have many places we have physical therapy at Rothman, other practices around the area that work with us. We're happy to refer you to proceed with that and go from there. Or we can try oral pain medications, and that's another option. But anyway, so I'm going to let Ryan speak a little bit about physical therapy, and then we can entertain your questions.
Hey everyone, my name's Ryan. I'm Dr. Canseco's physician assistant. Like you said, I just wanted to spend some time to go over more of the non-operative treatments that we can do to help treat back pain and some of the lumbar stenosis. 9 out of 10 of our patients, they get improvement with medications like anti-inflammatories, muscle relaxers, physical therapy, things like that. And then when that fails, like Dr. Canseco said, that's when we start to approach with more of a surgical outlook. So at this slide, you can see types of anti-inflammatory drugs that we like to use are things like ibuprofen, Aleve, Celebrex, and then indomethacin is a really popular one that we like to use in our practice. We see a lot of our patients get good relief with that. Gabapentinoids, those are medications that target nerve pain directly. So if you have tingling, burning sensation, numbness in the legs, gabapentinoids are medications that can help alleviate some of those symptoms. Those medications include gabapentin and Lyrica or pregabalin. Muscle relaxants can also help. A lot of people that have lumbar stenosis, they have a lot of muscle tension in their low back. So things like Flexeril or Baclofen can help loosen up that muscle tension and help give some kind of pain relief. But then the big one is physical therapy. We send a lot of pretty much everybody to physical therapy at first to see if that helps. But the most important thing about physical therapy is make sure that you kind of make it your part of your daily routine. Even when you're done, you do your 6 weeks of physical therapy, they'll give you a bunch of exercises and you want to continue doing those just so you can stay limber and stay strong in the back. Next. Next. All right. So like Dr. Canseco said, people get a lot of relief with people with spinal stenosis when they're leaning forward on shopping carts. So physical therapy really likes to focus on flexion activities. As you can see in this diagram here, that's more like bending forward to help give people relief. The idea of this is to help improve stability of the spine, and it opens up the disc space and gives some of the nerves some room to breathe. So that will help alleviate some of the pain. Next. So I just wanted to give everybody a couple exercises that they can do at home to try to alleviate some of their pain. So this one is the double or single knee to the chest exercise. You can lay flat on your back, make sure your feet are flat to the ground, and then you bend your knees up towards the chest. What this is going to do is, if you look at this, the bottom picture there, this is going to open up the disc spaces in the lower back, allowing those nerves to get some kind of relief. Next. The next one here, this is sit-ups are really important. As you can see, when they're bending forward, that's going to give relief on the nerves. But also what's really important is it's going to build some abdominal muscle strength. To help prevent back pain, we want to build a nice strong core, and we want to build a nice strong base in our legs so our back doesn't have to work as much. This is going to allow the spine to be more stable, and it's going to help allow those muscles in the back to start to relax while larger, bigger muscles start to take more control. Next. And then, like I said, you really want to build a nice firm base in your legs. So things like hamstring exercises and squats can really help do that. The picture on the left, this is your classic hamstring stretch. So you bend the one leg in towards the other inner thigh, and then you lean forward to try to touch your toes. That you should feel a nice burning or stretching sensation in that thigh, which will help limber up that muscle. And then the picture on the right here is for people if they have significant back pain and they get too much pain bending forward. If you have a towel or one of those like exercise rubber bands, you can wrap it around your foot, keep the leg straight, pull it up, and you should feel that stretch in that hamstring. So that'll help build strength in the hamstring and help loosen up the muscles. Next. So this is one of my favorite ones. I do this pretty regularly myself. You want to sit in a chair, and then you can just bend forward and let gravity do a lot of the work for you. You can even do this standing up. You can grab your arms, cross them like this, and then just bend forward and do like a little bit of a forward fold. If you do yoga, you're probably pretty familiar with that one. But this is going to let gravity do all the work. Let those hands just go right between your legs. Try to touch the ground if you can. Don't push yourself. You don't want to strain your back or anything like that. But this is going to give a good stretch to those back muscles, and it's going to alleviate a lot of the pressure that's causing the back pain and some of the numbness, tingling that you're having in your legs. Next. So mechanical traction is something that we see a lot in physical therapy facilities, and a lot of our patients get good relief with this. So the idea of this is that they put a machine on you, they'll wrap a belt around your waist, and then on the right side of this picture, it's connected to this machine, and that'll pull the brace towards it and add a little bit of pressure. And it kind of, if you have your vertebrae right here, it kind of separates them a little bit and opens up that disc space to give those the muscles a good stretch and help relieve some of the stress that's going on in the joints and the nerve roots. So, like I said earlier, the most important thing about physical therapy is maintaining it. You do your 6 weeks of physical therapy, you go home. You don't want to stop. You don't want to stop your treatment there. You want to try to make it part of your daily mantra. Home exercise programs vary from person to person. Some stretches might not work for people and they might want to try something else. And sometimes it's difficult to do it every morning, but I try to say if you can do an exercise 3 to 4 times a week, you're going to be better off doing that than not doing anything at all. So why do all of this? So physical therapy, home exercise program, stretching, strengthening the muscles in the back, the abdomen, the legs have shown to alleviate pain, and it's also shown to slow down arthritis. So if you have a lot of arthritis in your back, you don't want it to get worse. We can't stop it completely, but with these different kinds of activities, we can really slow it down. And then I left a link here. It's for the American Academy of Orthopedic Surgeons. It's a spine conditioning program. I like to give this to every single patient. It's a full stretching exercise from your neck, the middle back to the low back that I like to give out to help people build muscle and loosen up the muscles in their back. Because the less tightness that you have in the muscles, the less pain you're going to have. Thank you for everyone for listening.
All right, guys. I was trying to answer a few questions from the chat, and let's see. I wanted to, thank you for participating, Ryan and everybody. I want to thank Chet Donnelly. He's one of my friends and co-fellows. He lives in Dallas, and some of the slides came from him as he gave one of his patients a similar talk. And so it's a very important condition to treat. It is very common, especially as our population gets old. As medicine gets better, our patients are living longer, and you develop arthritis. Unfortunately, like I said, we don't have a hip replacement alternative or knee replacement alternative for the spine. So arthritis is a real thing in the spine and can lead to symptoms that can definitely be treated with or without surgery. And so if you're one of those people that has issues with something like this, please don't hesitate to reach out to us. Melanie provided your number. I can also put the number for our practice directly if you want to reach out, 609-920-9220. And that's, if you can give us a call, leave us a message, and we will be happy to call you to make an appointment to see us the following morning. And we'll call you back the following morning, but we are happy to see you within a week. We have plenty of space to see people within a week of giving us a call. Now, anybody has any other questions, I'm happy to answer those. I see a few. If you guys can go I can read them and give you some answers. A new question that we just had is, how about traction machines or acupuncture? So traction machines are something that our physical therapists use when you have compression of the nerves. There's some machines that it can pull you up from the neck or pull you down from the back or stretch your back to relieve that compression. And they definitely work. But I would definitely advise that you do it with a professional, with a physical therapist and trained. I've had patients that get stuck with some of those traction devices at home, and it's very difficult to get out of that situation without assistance. So definitely seek a professional, but they work. And acupuncture, it definitely works. It's an alternative form of medicine. The research has recently shown that there is some validity to some other treatments. It doesn't work for everybody, but if you're a person that that has tried other things and it doesn't work, I've had patients that have successful treatment with acupuncture. The only problem is that not many insurances cover it, so it can get expensive at times. Another question we have: what does a TENS unit do for back pain? So that's a form of electrical stimulation that can help with back pain and muscle weakness. It's usually used by physiatrists or physical therapists, and it's a machine that develops electrical impulses directly to an area of your body, either leg or back, and can help with modulating pain and strength and help you with improvement. So it's another option for treatment. And that's pretty much it. I have other questions that people have asked. One came and it's about the mild procedure, and that is it's a minimally invasive way of doing a decompression. It is generally done by pain management physicians. I've had patients that have had it with success. Many of them, unfortunately, is not very successful. It's not done by a surgeon in general, and it cannot achieve the degree of decompression. But I've seen patients, especially those that are not healthy enough to undergo surgery, have significant heart disease, lung disease, or kidney disease, have some success with it. So if you're interested in something like that, you should seek. It tend to be pain management physicians. What the other question that I had is so if you have spinal stenosis and an extension of your back helps you, should you not do it and you avoid flexion? And at the end of the day, it's what works for you. If extending your back leads to pain relief, if you have arthritic disease over time, that you're not necessarily going to hurt anything, as long as you don't have an unstable spine from a trauma. And so if that helps you, that by all means you can do it. My recommendation is that you see a provider that gets the appropriate imaging and examination to determine what's the best form of treatment. And sometimes you see a physical therapist that says, you know what, in your type of pattern of disease, an extension treatment will help your symptoms. And by all means, it's another way of treating your condition. And let me see if there's another one. Oh yeah, and that's pretty much it. Related to the topic, there's a couple others that I answered already. They're not necessarily related to this.
Dr. Canseco and Ryan, thank you so much. This was valuable information. I myself had L4, L5 issues, bulging disc, pain down my leg. So as you were talking about the exercises and stretching, I'm like, I have to get back to it because I'm better, but it's residual. You never know what could come back. And it's so important to take care of our back. So thank you so much. I know everyone has issues like this. I think this is very valuable information. Dr. Canseco also has a lot of videos on our YouTube website. So check it out. You can go through yourself. Maybe there's another topic that we didn't cover for this evening. So go through the library on our Rothman YouTube, and you'll have so many choices out there. But again, thank you so much, Dr. Canseco and Ryan. It was greatly appreciated. I hope everyone took away something. And if you have any questions, they were so kind to share their clinic number, 609-920-9220. If you have any questions, feel free to email us as well. Thank you, everybody.
All right, everybody. Thank you so much. Have a great night. Thanks, Melanie.
Oh, you're welcome. Have